Wish I knew what Rita just said. I didn't have my earphones on. But I'm thinking about the first time that we met, and I heard her story and just how remarkable it is. And it's a real honor to be here, to be invited. It's a wonderful program, and I'm hoping that that in this home of the Nobel Peace Prize, that our proceedings here and what we say and what I might say might have a little to do with bringing more inner peace to the world. I'm going to be talking today from my clinical experience. Feet on the ground, in an emergency room, in the trenches. What do you do when a patient comes in the door and they are psychotic and have drugs in their urine? We know they've been using drugs. I'm wondering, by a show of hands, how many people here have treated someone who's been psychotic before? Oh, lots of hands. Okay, all right. So I see a number that have not. Can you raise your hands if you have not treated anyone that's been psychotic before? Okay. You've seen them. Okay. So it's a good mix of both. So I'm going to be speaking from my clinical experience. I'm an emergency room psychiatrist. I've been doing that for about 10 years, and it's fitting my yearning more and more because I simply have difficulty sitting still for 8 hours a day, in a chair seeing people in an outpatient setting. But have set up acupuncture, acu-detox programs on inpatient units. Where I work, we have a now close to 60 beds inpatient on the psychiatry unit. It's a general psychiatry unit that treats a whole spectrum of psychiatric patients. In the emergency room, of course, we treat whatever comes in the door. And often you don't know what that is coming in the door. Of course, the extremities of depression can turn into psychosis. The extremities of anxiety can also look very psychotic. In addition to the psychiatric disorders per se, such as schizophrenia and schizoaffective disorder, where psychosis is a part and parcel of the diagnosis itself. Laura's mentioned one of the primary research articles that I had published. I've had a couple other endeavors. We're looking now at using beads in our psychiatric partial hospitalization program for children and adolescents that we're very excited about. We had our pediatric psychiatrist that came on board as an investigator with that. And I know that people that I've been speaking with are eagerly awaiting to get something more formal with regard to that. But much of what I'm going to say, you've already heard, and I hope I can bring it to a summary conclusion to try to put it all together in terms of just putting words to how acu-detox, the NADA protocol, helps with relapse prevention in those who are psychotic. So I'm going to do this by way of talking about a case study. And the case study is really illustrative of what has propelled me as a psychiatrist to hold on so tightly to the NADA protocol. I was 2 years after college and decided I would take a break from medical school to travel around the country to see if alternative medicine really helped really sick people. And I ended up spending 6 months at the clinic in Lincoln. I like to think of it as the Wild Wild West in those days because we treated anyone that came in the door with anything. And it was just such a wonderful experience. Everything from psychosis to strokes to broken bones, back pain, anxiety, in addition to addiction. So the patient I'm going to talk about by way of case study that I'll then use as an example of the many ways in which NADA can help with relapse prevention in terms of psychosis. It is quite parallel with the way in which it's used for relapse prevention and addiction. The parallels are entirely striking, And if you're familiar with how you've been using it in addiction, for those who have not treated psychotic patients, it is extremely parallel for other aspects of behavioral health. In fact, the NADA organization, the NADA board decided, I guess 7 or 8 years ago, that we would change our mission statement from education and advocacy for addiction to education and advocacy for behavioral health, including addiction. And all we are doing, again, is putting words to what the patients, the many patients that have been treated, have taught us through the years. And Mike is certainly very articulate about how none of this arrived on his desk or in his brain de novo, but it was really learning from the patients as we went along. So here I am, an eager medical student who's taken a leave of absence to see if alternative medicine really works. I walk into the clinic and I'm ready to start reading stuff. You know, what can you tell me? What can I read? Where are the articles and stuff? And at that time, it was Carlos was in the clinic. I don't know how many of you have met Carlos, but you have, okay. But they made it very clear this is not that kind of party, right? This is something that has to take place from the inside out. We want you to have an experience first. So I had my experience, and a couple weeks later, after I had went through the slow organic trainings that they did, lots of hands-on stuff, I remember after the second day or so, Mike directed me to treat a patient who came in. This was a patient who was having command auditory hallucinations to kill himself. Had been out smoking crack all night long. He's sitting there, he's wide-eyed and bug-like this. He's twitching, tremulous in the chair. I could get enough of a history once I went through an experience similar, I think, to what Sheila had described, because, again, I'm a medical student coming into this setting for the first time, of thinking, wow, is he going to let me treat him? What am I going to do? He could barely put 2 words together. And, of course, I treat this gentleman, and he sits back. I'm sitting there staring at him the whole time. And gradually he calms down and goes to sleep, and I just continue staring, waiting and anticipating that he might jump up and do anything at any time. So a little over half an hour later, he wakes up. And, and generally after we treat patients, we really don't want to do a treatment autopsy and have them talk about what happened. But this was a learning experience. So I'm not encouraging you to do this with every client, but I did this with him. And what he had to say to me was that he was still hearing the voices. We had talked about a half an hour or so about other aspects of his history. The voices were intermittent, which means they weren't there as constantly or incessantly as they were before. But they were not telling him to kill himself. Now, if he had come into the emergency room where I work now, and virtually any other clinical mainstream setting, what would we have done with him? Shots. Shots of what? Haldol. Yes. Yes to all of that. We would have given antipsychotics and Ativan. Our go-to, sometimes we vary it if it's indicated, but usually it's Haldol 10 and Ativan 2, and that will basically take down the most difficult person that comes into the clinic. But of course, one of the most remarkable parts about this gentleman is that he did not come on an involuntary commitment. Now, this is somebody who's psychotic. He's been smoking crack all night, can barely put 2 words together. And what he thinks about doing, as these voices are getting so strong, telling him to kill himself, is to come to Lincoln to get a treatment. That is relapse prevention. So, because generally, it's difficult to have this sort of conversation with folks. So what that says is a lot. And again, what I hope to do is put words to what we know about the NADA protocol. The first step to really looking at manifesting hope and a hopeful outcome is engagement and retention. And you can't have a better vote for engagement and retention than somebody who keeps coming back. And so even with the most psychotic of patients, this still works, just like it does with an addiction. As a matter of fact, again, upon Mike's recommendation, I had the honor of being a co-author for guidelines for best practices in addiction treatment in the United States through the National Institutes of Health. First time in U.S. history, they endorsed an alternative medicine as a best practice. And where they hung their hat was on the idea of engagement and retention. So I've been talking to many folks who've been telling me they've had difficulty moving AccuDetox over into the behavioral health side of the equation in addition to addiction. But if we think about the way it works for basically any drug of any persuasion at any stage in the intoxication or withdrawal process, it's just a no-brainer that it should work for basically everything we do and treat in psychiatry. So this first issue of the keep people coming back was what I saw on this first patient. One of the bedrocks of engagement and retention, and the spirit of NADA will do that. Secondly, one of the things that the patient also learned in a nonverbal way was that he could feel better without the use of the Haldol or the Ativan, of whatever he was withdrawing from or looking for some other street drug to offset that. That's a message that you can use 1,000 words trying to talk about, and you cannot convince somebody that that's so. If we think about the first treatment that we had, if somebody had told you that putting stainless steel needles in your ear would help you to feel better, what would you have said to them? Right? So to have a setting, a group setting where this is taking place, easy access, virtually barrier-free on any given day, and to let patients see that, and to really experience, without the 1,000 words, that they can feel so much better in a half an hour or so, is a very powerful message to give. That is relapse prevention. We think about why the Ativan. Now, of course, NADA cut its teeth on the opiate epidemic in New York back in the 60s and 70s, but quickly learned, again, through the patients, that it worked for the alcoholic, it worked for the crack addict, it works for the person using hallucinogens, PCP, so virtually any drug of abuse that you would never think of even having a medication for to really support through the process. Not a protocol can do that. But again, why is Ativan and the idea of benzodiazepines such an attractive medicine for so much that we do in psychiatry? We know that the element of anxiety, the element of distress and stress, makes anything worse that's coming through the door. If it's pain is very subjective. We heard Libby is talking this morning about those looking for marijuana, looking for severe pain. Now, for those that are on, I don't know about the 94%, but we'll give them 10% of severe pain, really needing to deal with that element of distress. Simply to reduce that will decrease their subjective perception of the pain. So pain is more than just a physical symptom. It has an emotional component, it has a cognitive component. Sedatives work within that setting. We give Ativan to folks who are psychotic and drug abusing. We'll combine Ativan and Haldol. If they come in and they're having a panic attack, we reach for Ativan to give to them to calm it down acutely. If somebody comes in depressed and they're wailing and hysterical, we reach for Ativan or something like that for that patient. If they come in and they have dementia and they're extremely paranoid and can't be calmed down, we reach for a benzodiazepine and potentially an antipsychotic. So these categories, diagnostic categories that we find, the latest one on the psychiatric side is the DSM-5, of course. They are not based and correlated strongly with treatment at all. The treatments that we use cross the diagnostic categories. Ativan is one of those medications that we can reach for almost whatever ails you, because it helps to decrease that element of distress. NADA protocol for mild to moderate anxiety and depression, again, is just as good as any medication that anybody can prescribe. If I had one tool to use out of everything that I've ever been exposed to use that would help the most people most of the time with the least risk of side effects and liability, it would be the NADA protocol. In the over 40 years, please clap. Let's get a hand for that. Yeah. I'll just let you know that I was doing something a couple years ago and had Sarah and some others assist me in tracking down, well, what's the record of liability claims against NADA practitioners in the United States in the over 40 years that has been existing? Somebody guess a number. Don't give it away. Don't give it away. Somebody guess zero. Absolutely zero. And so we know that much of the reason why NADA protocol is not more widely used, it ain't because of an evidence base. Lars just went through lots of the evidence that is here. We have a strong evidence base. That's my position, just as strong as many of the psychotropic medications that are used, cardiac medications that are used, that we know have tremendous liability. And the years and thousands, hundreds of thousands of patients that have been treated with the NADA protocol, it ain't about the evidence base. It's about getting the voice and a political presence to make this wonderful tool more available. What about sleep? Oh, okay. What about sleep? Sleep is important in everything as well. We know that there are certain stages of sleep that patients are supposed to have in order to have it be restorative and to assist with their resilience and to really help to restore them to wholeness. Virtually all of the antidepressants we prescribe, the benzodiazepines, antipsychotics, they mess up your stages of sleep. NADA protocol helps to restore that. We didn't need a diagnosis. To have this as an upfront barrier-free tool for folks who may not be ready to talk, you have to have something that is homeostatic, something that will help to balance them no matter where they are. And that way you don't have to be, to put on a diagnostic hat and figure out what diagnosis is there in front of you, trying to get somebody to tell you, how they were bad, how bad they've been, how much they enjoyed being bad while they were being bad, and think you're going to get the truth about all of that. We need a tool that will help to balance no matter what they say. If they lie, if they tell the truth, if you get the diagnosis right or wrong. So again, this first patient that I saw, I didn't have a diagnosis. I was told he was schizophrenic, but we know that can look like, what can look like schizophrenia is the drug abuse. Was he severely depressed? Was there an organic problem that was going on? This helps to clear the static. And so even for someone who wants to wear that diagnostic hat, it is good to have something that can clear the static, so you really see what's in front of you in order to get the best history possible from somebody who can actually talk to you. And the NADA protocol does that as well. I will end before Rita gets the hook and kind of pulls me off stage with the idea of that one of the things that was so impressive to me with Lincoln program when I was there, as it was thriving, was the use of peer counselors. We know that for axis 2s, and most people who are using drugs have some sort of an axis 2 component, from acting out to the lying to the antisocial behaviors. There is nothing that psychiatry has to treat that. As a matter of fact, during in my early days of psychiatry residency, I was even more drawn when I read that for the major problems affecting us in the United States in terms of the addiction, the high crime rates, the prison rates. Psychiatry has basically zero to offer that population in terms of addressing the that access to component. So even for those who are with drugs, who are psychotic, for those who have all sorts of behavioral problems, everything that you've learned about addiction is parallel to what you find with psychosis. They often go together. You have a wonderful tool in your hands. And again, my observations are not unique either. They're shared by many of you, and thank you for the opportunity for me to sing my song.